the first time that I started getting involved in the Children's Tumor Foundation, and I can't remember who told me, but the first thing they said is to please register.
So one of the reasons to join the NF registry is you get to hear about all these cool opportunities that are for drug trials or research opportunities.
Your information goes into the registry bank, and not only are they making a difference for you, but they are also making a difference for every single person that has NF.
I think everyone should join the NF registry because, first of all, it doesn't hurt. It doesn't cost you anything. It doesn't take any time. You just get emails that tell you about really cool research opportunities that oftentimes give you benefits, whether that be money or trips to different cities, and you get to be a part of their research and give them data that can help them develop new drugs that can help you, that can help other patients with NF, even if you don't really feel like it would help you personally, knowing that it will help someone else with NF and knowing that they could be a part of a trial that could help you. We're all a family, so whatever you do can help someone else just like yourself.
So every single person that's sitting out there that has NF, that is not sure what to do, register, and let's make a difference for NF.
So I'm going to be talking a little bit with you guys about navigating family building. Sometimes we call it family planning, but I like the term family building a little bit more when you have NF and schwannomatosis. And I want to start with just a little poll, a little word cloud we can do. So when you hear the term family building, what types of things come to mind? What words come to mind for you? And we have the option, you can text to give your responses, or if you want to call some things out, we can do that as well. I'll give you guys a minute to do that before I get started. What kinds of things do you think about? Are there words, are there phrases that come to mind when you think about this concept of family building?
It doesn't necessarily have to be blood family as well. Family building, you could have a circle of friends. I have a good friend and we say, we always say to each other, this family by blood and family by choice.
Yeah. I'm going to repeat that. So family is not necessarily blood family. That's something that people think about. Yeah, there's many ways that you can call someone your family. I don't think we have any. I'm not sure if it's not working, but if anyone else wanted to shout something out, or Emily can bring the mic.
Genetics.
Genetics, yeah. A few different things. Sometimes we don't know what to say when we think about this, and we're not ready to kind of think about these things out loud, but we can kind of get started on the presentation as well. So when I think about family building, it's the decisions that we make about if, when, and how we add to our family. And that can look differently for different people, including blood relatives or non-blood related relatives. And there are many different factors that can play a role in this family building. They might be internal factors, thinking about your own health, your own well-being. They might be more external factors. They might be things like your housing situation, the time that you have, your religious affiliations. There's a lot of things that can play a role in deciding to build a family or not. And medical conditions like NF can be part of it as well. But they're not the only thing that plays a role. So I'm going to start just by talking a little bit about genetics and inheritance of NF, just to get us kind of like a baseline for that. So when we talk about NF1, everyone who has a pathogenic variant in the NF1 gene will develop symptoms. But we do know that there's a high degree of variability even within the same family that can make it challenging to predict the health of people that might be born with NF. About 90% of the time, the genetic mutation does not predict the severity or the set of symptoms that someone has. But we are learning that a small number of people, probably up to 10% of people right now with NF1, they do have a genetic variant that can be predictive in some ways, but not 100% of health in the family. I've listed a few of them here. You can always talk to your healthcare provider and ask them, do I have one of these genetic variants that has some more information we've discovered recently or not? And we do learn things over time. A few of these we only discovered a couple years ago, so this does change over time. For NF2, just like with NF1, we know that everyone that has the variant does develop symptoms of some kind. We have a little bit more information about how the genetic variant plays a role in it though. So there have been some studies that have shown associations between the mutation that you have, where it is in the gene or the type of mutation in NF2, and how likely you are to have symptoms at a different age and how they might change over time. So in families with NF2 schwannomatosis, people tend to have a similar presentation, a similar age of onset. The exception to that is if someone in the family is mosaic, which I'm going to go over a little bit, they tend to be a little bit milder than other people in their family that are not mosaic. And so we look at the location of the gene and the type of variant, and that can help us with NF2. For other types of schwannomatosis, so LZTR1 or SMARCB1, or sometimes you have schwannomatosis and we're not exactly sure which gene is causing it yet, we do know that some people can carry the genetic mutation and not develop symptoms in their lifetime. And we're not completely sure how often that happens. We're still learning that because of the rarity of schwannomatosis, but it's possible to have a genetic mutation and never develop a tumor. We call this incomplete penetrance. We can see variability within family members with schwannomatosis, and right now we don't have a way of predicting severity based off of your genetic test result, but we might in the future. We do know that there's sometimes risks of other genetic conditions due to the same genes that can cause schwannomatosis. So the LZTR1 gene that causes one type of schwannomatosis can actually sometimes cause a different condition that is similar in some ways to NF1, can have developmental differences, sometimes some heart defects called Noonan syndrome. So some people might, if they have LZTR1 schwannomatosis, talk with their genetic counselor or their clinic about whether they need to be investigated for that risk in their family. In general, regardless of the type of NF and schwannomatosis we're talking about, the risk of passing on a mutation is 50%. And that is because these conditions are all what we call autosomal dominant. They are carried on chromosome 17 or 22, which we call autosomal chromosomes, which means they're the same whether you're male or female. So the risk of passing it on doesn't change whether it's coming from the mother's or the father's side, and it doesn't change whether it's being passed on to a boy or a girl. We have 2 copies of chromosome 17 and 2 copies of chromosome 22. And so if you have a mutation on one of those chromosomes, there's a 50% chance you pass it on the one with the mutation and a 50% chance you pass on the one that doesn't. And that's the general risk in NF and schwannomatosis. That risk can be a little bit different if you have mosaicism. And this is something that sometimes happens in people that are sporadic or spontaneous cases of NF and schwannomatosis. So you don't have a family history. And what can happen, I'm going to maybe use this one, is that the mutation that is in the NF gene or the schwannomatosis gene, it doesn't happen in the sperm or the egg, it happens after you're conceived. So when you're a really small embryo and the cells are dividing, sometimes a mutation can happen during that process. And so a small portion of your body ends up having the mutation. You can see in these blue colored cells here, but the rest of the body doesn't have the mutation. And the degree of your body that has the mutation differs depending on how early or how late the mutation happened when you were growing in the womb. When people are mosaic, sometimes the mutation can be found on a blood test or a saliva test, sometimes not. Sometimes it's not in your blood cells or your saliva cells. We can usually find it though if we test something directly related to your NF or schwannomatosis. So if you have a genetic test done on your tumor or on cafe au lait spots or freckles, if you have NF1, we can find it there. Sometimes the mutation can be in the sperm or the egg and passed on to children, but not always. And so sometimes when you're mosaic, the risk of passing it on is not 50%, it can be a lot lower than 50%. There's a couple ways that we can figure out if someone is mosaic. If we do a blood test and we don't find anything on that test, or if it comes back at a really low level. If you have cafe au lait spots or freckles or tumors that are kind of all limited to one part of your body, you're much more likely to be mosaic than if it's more spread on both sides of your body. And sometimes we need tumor or skin biopsy testing to confirm that. Mosaicism is a lot more common in people that have schwannomatosis. So if you are a sporadic case, it's probably a 50% chance in general that you could be mosaic. In NF1, it's a lot less common, so probably about 10% of cases. And usually we can see by looking at the skin exam whether you're suspicious for mosaicism or not. But this can play a role in our family planning decision making. So when we think about family building, Sometimes there's some big questions we have to think about first. First of all, do you want children? And then, do you want children that you share DNA with? And then, does my NF play a role in how I make my decision making about having children? And these are big questions, and they're not easy to answer right away. And when I think about family building options, I tend to put them into two main categories. Are we talking about children that are not genetically related, that are not blood related, or are we talking about the potential for children that are blood related? So under the category of children not related, you could choose not to have children. You could choose to adopt, foster. You could use a donor, like a donor sperm or donor egg instead of your own sperm or egg. For those that are in same-sex partnerships and you're deciding whose sperm or egg to use to build your family, you could choose the person who does not have NF. And then in the other category about choosing children that are genetically related to you, we can evaluate children after they're born. And sometimes children are born before someone is diagnosed, so we are evaluating them at that time point. You can choose to test when someone is pregnant, and then you can also choose to test embryos as part of fertility treatment and IVF. I'm going to spend a bit of time talking about the options of genetically related children and the different testing that we do as part of this presentation. So first, evaluating children. So this can be done if we know the genetic mutation in the family. It can also be done if we don't know it or we don't have access to those genetic results. There are limitations if we don't know the variant in the family because we are talking about clinical evaluations or imaging evaluations. And the timing of when we do these evaluations differs a little bit depending on what type of NF we're talking about. So if there's a risk for someone in your family to have NF1, most of the time, the symptoms of NF1, the cafe au lait spots, the freckles, they develop at a pretty young age. So usually we have a good sense of someone's risk in infancy and early childhood. And they meet clinical criteria for NF1 pretty young most of the time. So we don't usually need genetic testing to know for certain by the time someone is a certain age. For NF2 schwannomatosis, usually we talk about doing evaluations such as MRI screening of the brain and the spine around the age of 10. Because for most families, that's an age when a child can do the MRI without being sedated and having to go to sleep for the scan. And also the chance of having an NF2 related tumor that we need to intervene with is very low below that age. But there are exceptions to that. So there are families where we look at the mutation or we look at the family history and when other people in the family have been symptomatic. And your providers might say, you know what, we need to start those MRIs a little bit younger than that because there's a different risk in your family. But sometimes we might do other things as well, like seeing the neurologist or the eye doctor at a younger age, because those are low-risk clinical evaluations that we can do. For other types of schwannomatosis that are not linked to NF2, generally we're talking about a risk of adult onset or teen onset tumors, so we start evaluations around that age because the risk of having something develop younger than that is very low. Another option that we can think about is testing during a pregnancy. We call that prenatal testing. This is a type of test where we need to know the mutation in the family for it to be an option because we need to know what we're testing for in the pregnancy. These are invasive tests that do carry a risk of complication because they need to test the DNA within the womb in order to find out the status for the fetus. There's 2 time points where this can be done. It can be done at the end of the first trimester by testing DNA from the placenta, which has the same DNA as the fetus. It can also be done later in the second trimester by testing a sample of amniotic fluid from around the fetus. These are procedures that are generally covered by insurance and are usually considered if someone is thinking about abortion of a pregnancy depending on the genetic status, which not everyone is interested in that as an option for their family. There's also limitations to access to these types of procedures depending on where you are in the country. And then finally, some people think about in vitro fertilization or conceiving with a fertility clinic and testing embryos using a process called pre-implantation genetic testing, or PGT. We need to generally know the NF mutation in the family for these options. It is a long process with lots of different tests and procedures involved that I'm going to go through, and sometimes insurance coverage can be challenging. There are 2 types of pre-implantation genetic testing. When we talk about PGT for NF and schwannomatosis, we're talking about an option called PGT-M, or monogenic, which means testing for a single gene disorder. So that's what the type of test that we would do for that. There are other types of PGT, including PGT-A, which means aneuploidy, which means we're testing the chromosomes. So checking for things like Down syndrome and the number of chromosomes in an embryo, which is more of a general screening test that's used to check embryo quality many times, but can't diagnose NF or schwannomatosis. So IVF is a long journey. It can be quite complex. There's a lot of steps involved. There's consultations to check your fertility health of you and your partner if you're doing IVF with a partner. They have to make a custom test to your mutation, and that can take a couple months to do. They need to collect the eggs, which involves stimulating the ovaries with hormones, waiting for them to mature, and then collecting them, fertilizing the eggs. When we do genetic testing, we let them grow for about a week so they get a little bit larger, large enough for us to take a biopsy out for the genetic test, and then we gotta wait for those genetic test results to come back. Depending on the results of the genetic test, you might have an embryo that you would like to choose to transfer to the womb, and then wait to find out if you become pregnant from it, and then wait for the rest of the pregnancy. It's not always a linear process with IVF because we don't always get the results that we're looking for on the first try. Sometimes we don't get enough eggs, so we have to do multiple retrievals in order to get a larger number. Sometimes those embryos and those fertilized eggs don't grow that well, and we don't have a lot of candidates for genetic testing. So again, we're looking to get more eggs for sampling. Sometimes we don't get the genetic test result we're looking for, or someone doesn't become pregnant from a transfer. So sometimes there are parts of this process that need to be repeated to ultimately get to the end where you have a child born from the process. However, in general, for people that are going through IVF that are under the age of 35, because age plays a role in the number of eggs we're able to retrieve from any one cycle, and for those that don't have other fertility issues that are impacting them, there's a pretty good chance that you can get a baby born from the end of a single cycle with IVF. A lot of statistics around success rates from IVF are based off of people that are going into that process because they have difficulties conceiving naturally, not people that are going into this process because they're testing for a genetic condition. So just to talk a little bit about what we mean about the embryo testing and what's involved, there's a couple different types of PGTM. The one that's traditionally been done the longest is something called linkage PGTM. And that one doesn't directly look at the gene, doesn't directly look at your mutation, but it links it to which chromosome in your family is the disease following through. So in NF1, which chromosome 17 did you inherit from your parent and your grandparent that had NF1, for example? Or if you have NF2, which chromosome 22 is being passed down in your family with the condition? And so they use, if you were at my talk earlier about different variations that we have, and we have these polymorphisms in our DNA that show how we're related to each other, they use the same type of test to figure out where are the chromosomes coming from in your family. And they link them, so in this example, that you can see that they were able to link using the letters D, E, F to say, okay, this is the chromosome in the family where the NF is, and that's what we're gonna test the embryo for. Sometimes, most of the time we do this if you have a familial case of NF or schwannomatosis. Sometimes we can do it if you're a spontaneous case. So if you've already had a child born that we know the genetic status of, they can track the chromosomes that way. Sometimes they can do the same thing within the embryos when they're doing the testing. But this is usually done if you have a family history of NF or schwannomatosis. And it's available at most fertility clinics, at most laboratories. The other method of PGTM is what we call direct PGTM. And this is something where they're directly looking at your specific mutation. It's a specialty test that can be done for people that are spontaneous cases of NF. And it's not looking at the chromosome, it's really looking directly at your mutation. And what they do is the person that has NF or schwannomatosis, they get a sample of your DNA where the mutation is. If you're mosaic, it might be a sample of DNA from your tumor or from a skin biopsy. And they take a couple cells out, because an embryo test is just on a couple cells, and they run it through the laboratory to see, can we pick up your mutation or not? And if they are, then they're able to do it on embryos. The challenging thing about direct PGTM is it is a specialty test. It's not offered at a lot of laboratories right now, so you do have to ask your fertility clinic, where are you doing my testing? And it doesn't always work for all types of mutations. So some mutations are harder to detect than others. So there are challenges to doing embryo testing. With the linkage method, If you have a family history of NF and your parents are passed away or they're not available to submit DNA samples for that fingerprinting of the chromosomes, it might be challenging to use this. If you have sporadic NF and they're doing the linkage using your embryos, it depends on how many they have for that process. For the direct type of PGTM, you need to start with a detectable genetic variant, which there are some people with NF and schwannomatosis where we cannot detect your mutation with the laboratory technology we have today. We also know that certain variants it doesn't work as well for, so we can't do right now direct PGTM if you have a large deletion or a large duplication. If you have a smaller mutation that's a couple DNA letters, it usually can detect it, but really the lab needs to confirm first. And then with mosaicism, if you're a mosaic case of NF or schwannomatosis, we need to make sure we get a DNA sample that has your mutation in it to create your probe. So thinking about preparing for family building with the information that we have. So I recommend that if you're thinking about family building options, that you get your genetic testing done early, especially sometimes it can be time consuming to do genetic testing. If you're just doing a routine blood test, it takes about a month. But if you are someone that needs to do tumor testing or skin biopsy testing, that can be several months to get your results back, especially if you're mosaic. I recommend if you have genetic testing or if you're saving the results for your child for the future, keep it in a safe place because it uses standardized language. So once we've detected your mutation once, we don't need to go looking for it again if we have the original records from it. For males that have mosaic NF or schwannomatosis, we actually do have the option of doing genetic testing on sperm samples right now that can directly assess what is the risk of you passing on your mutation to your children. Is it 50%? Is it less than 50%? So that's a specialty test that can sometimes take time to get done. Unfortunately for females with mosaic NF and schwannomatosis, we don't have a way of directly assessing the risk of passing it on, but sometimes there's some research studies we can refer to indirectly assess the risk. If you're thinking about IVF and PGTM, if you have a familial case of NF, you might want to think about banking DNA from your parents depending on their health, depending on their age, because if you have banked DNA from their parents and something happens to them in the future, then you still have the option of the linkage type of PGTM, which is more accessible. And you can also start thinking about like, what are my fertility clinic options? Asking your NF clinic about what's available in your area. You really want to look for a fertility clinic that has experience with genetic testing. Not all of them do. Some of them are more prepared for dealing with infertility than for genetic diagnosis. And you really want to look for someone who has a genetic counselor on staff if you can. The thing about IVF and PGTM is it can be quite expensive. And it's not always covered by insurance. So it is something that many people need to financially prepare for. Looking at what your insurance options are with your employer, if there are multiple options, do they have differences in the fertility coverage? Talking with your insurance provider, do they have certain things that you need to do in order to qualify for IVF? What do they cover? What do they not cover? Is there a cap on how much they cover? These are all important things to investigate and to estimate what your costs might be if IVF is something that you're considering. For the average cycle right now, once you take into account medication and embryo testing, it can be $30,000 to $40,000 for a single cycle in the United States. In terms of financial planning, some people use savings, other financial methods of saving for IVF for what's not covered by insurance. There are sometimes organizations that have grants or lotteries that can help with some costs. People might use their healthcare savings accounts as well, or fundraising. So there's lots of things that people can look into to help cover some of these costs that are not covered. Other things just kind of think about regardless of what type of family building option someone is thinking about. If you are someone who's thinking about carrying a pregnancy and you have NF or schwannomatosis, sometimes you have to think about your own health and how pregnancy might impact that. So especially if you're on certain medications that might be contraindicated when you're pregnant, talking with your healthcare team. Things like Avastin and Koselugo, those generally you can't take when you're pregnant or breastfeeding. So talking with your team. There might be other medications like that you take for pain or for epilepsy or for depression that you need to talk with your team about whether those are safe to be taking when you're trying to conceive. If you're going through IVF and you're collecting eggs or sperm, sometimes there's medications you can't be on during that process. When you're pregnant, and then when you're breastfeeding. So something to talk with your team about. You can also talk to your team about other things about your health. So you might want to talk with your team about, is there anything about my NF health right now that I should take care of before I become pregnant? So is there a medical procedure like a surgery that I should plan for? Are my MRI surveillance, like is my MRI up to schedule? Should I plan around a pregnancy for that? Because we might not be able to get CT scans or MRIs with contrast done during a pregnancy. Those are things to look at. We want to try to avoid doing things like surgeries and major medical procedures during a pregnancy. That can be complicated, that can be risky for different people. And also things like radiation therapy, of course, we want to try to avoid that during pregnancy. So different things to talk with your team about. And then maternal health in general, no pregnancy or delivery is ever going to be 100% safe. There are always risks involved with being pregnant and delivering a child. In general, most people that are pregnant with NF and schwannomatosis have good outcomes, and severe complications are rare. Your health before you enter a pregnancy can play a role. So if you're already going into pregnancy with high blood pressure or vascular disease, scoliosis, or brain and spine tumors that are being monitored, that could change things for you individually. We do know that in NF1, there are some slight differences in pregnancy outcomes. We see that high blood pressure is a bit more common in women with NF1 when they're pregnant. Preeclampsia is a little bit more common. And sometimes we see what we call IUGR, so the fetus is a little bit smaller than it would otherwise be during the pregnancy. And there are questions about how much does pregnancy impact tumor growth. So for meningiomas, an NF2 related tumor, we do know that meningiomas in the general population are more common in women, and more common in women that have been pregnant before. So it's possible for a woman with NF2 that pregnancy could impact her meningiomas, but we don't know for certain. And for NF1, we do know that there have been some small studies and also anecdotal reports from patients that you can notice a difference in your neurofibromas during periods of pregnancy. Most of those differences are in the neurofibromas of the skin, which we know are not dangerous, but can be impactful to someone's health. So there's a lot that we still need to learn more about for pregnancy, but in general, pregnancy is safe when someone has NF and schwannomatosis. And then thinking to the end of a pregnancy and a delivery, we do see that women with NF1 might deliver a little bit earlier, but no more than a week earlier than average. We do see higher rates of C-sections and lower rates of epidurals within women that have NF1. Part of that might be accounted for by concerns that women with NF1 might have spinal tumors that could impact getting an epidural into the spine. There are some guidelines from OBGYNs and anesthesiologists that are concerned about this risk, and they talk about getting clearance before a woman gets an epidural when they have NF1, even though in NF space, our adult guidelines don't recommend that at baseline unless you have symptoms. But we have encountered patients in our own clinic that need clearance from one of our NF physicians before they get an epidural. Birth defects are rare if you're expecting a pregnancy that has NF1, so I wouldn't expect that you needed to be at a specialty care center during your delivery. The types of things that might happen for a child born with NF1 are usually things that are like small heart defects that don't need major intervention. And then thinking about our NF2 schwannomatosis population, especially if you're deaf or hard of hearing, that can impact healthcare disparities and communicating with your healthcare team. So definitely talking with your providers if you're going through a pregnancy and a delivery about are we all on the same page? How are we communicating during a high pressure situation of delivering a baby? So in closing, family planning, it's a big decision to make. It's something that you can think about individually about what's important to you, but it's also something that you can talk to with people that you trust. If you have a partner, a family member, a religious advisor, your healthcare team, people that are important to you, and kind of walking through these different decisions that come to, do I want to build a family and how do I want to do that? Thinking about your values and your resources, your own health and your family member's health, and other things that can play a role. It can sometimes be helpful to just go through each of the options step by step and think about, how would I feel if I did this? How would I feel if this was the outcome in these different situations? And writing it down can also sometimes be helpful as well. So in closing, family building is a choice that you make, and it's unique to you. And any family building option can be the right choice for you. So thank you. I'm happy to open up to any questions.
Thank you, Kara. We do have one question in the app that I wanted to get us started with. How and when do people generally talk to potential partners about family building implications?
That is a great question, but I'm not sure if I have a great answer to. I think how much you disclose in dating and with partners and meeting new people is a really personal decision. I think that in the context of talking with someone about whether or not you want to have children and whether or not you might want to have children with that person, that might be a time to talk about those things. Or if you're in a space where you're talking about personal things in your life and medical issues and things that, if you're thinking about long-term planning with that particular person, that might be, from my own personal perspective, a time to start talking about these things. But I know that in different cultures, in different religious backgrounds, there might be different perspectives on how quickly someone discloses medical issues or how you think about building a family. So it is a really personal decision. I don't know if I have the best answer. Other questions? And if you feel that you don't want to raise a question in front of everyone else, I am going to be available afterwards and we can talk one-on-one as well.
We have another question in the app. I'll
Yes.
ask it. What genetic tests are available for determining gonadal mosaicism?
So gonadal mosaicism is tough because a blood test and a saliva test and a cheek swab test can all be negative and you can still have gonadal mosaicism. You can assess males for gonadal mosaicism because we can test sperm samples because sperm is continually being produced. We don't have a way to directly test for female gonadal mosaicism. If the question about gonadal mosaicism was from a place of concern about having a child born with NF or schwannomatosis and wondering if you could have a second child born even though you have no symptoms, then that is generally a low risk. So sometimes we talk about gonadal mosaicism because there have been cases in the literature where parents have no symptoms, no history of NF or schwannomatosis, and they have 2 children born with it. And the theory behind that is that a couple egg cells or a couple sperm cells have the mutation and the rest of the body does not. In general, that happens probably less than 1% of the time. So we don't often see it, but it has happened before. But we can test if you're male, we can test for it. If you're female, we don't have an option at this moment. Other questions from the app or the audience? Sounds like that's it. We have a couple. Yes.
In looking forward, what are you most excited about or what breakthroughs are you looking forward to?
I think looking forward, I'm excited for us to be better at treating NF and schwannomatosis and that this becomes something that we can prevent symptoms from starting or we can treat them really early. And maybe this discussion about family planning and doing testing if someone's concerned about the health risks and concerned about passing it on, maybe this becomes less of a relevant discussion because it's a highly treatable disease. So that's what I'm hopeful for, that this is not weighing, do I have a child with NF or schwannomatosis or not, but this is just, oh, this is something that we can treat and maybe this is less of an influence on my decision making.
Thank you.
I have another question back there.
I'm just curious, and maybe you don't know the answer to this, but when you were saying with insurance companies and finding out your qualifications, do they sometimes require like trouble conceiving rather than just having a genetic disorder that you want to avoid?
Unfortunately, yes, and sometimes they have that requirement for same-sex couples as well. So, yeah, the qualifications for IVF are sometimes not very relevant to the situation that someone is in, yeah. Mm-hmm. think that might be it. So I'm going to be off to the side. I know we have a couple more minutes and maybe a break. So if you want to come up and chat with me one-on-one, I'll be here. Thank you.